Welcome to the Skeptic's Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is July 27th, 2026, and I'm your skeptical host, Ken Milne. The title of today's podcast is A Whole Lot of Blood. Whole blood transfusion in the pre-hospital setting? And our guest skeptic is Howie Mell. And of course, Howie's been on the show before, but was neglectful in sending me an updated intro. So Howie, what are you up to now?
Nah, there's no updated intro. I'm just a permanent skeptic. Come on. I'm still working for Vituity. I'm working nights. I happen to be assigned right now at HSHS St. John, which is a level 1 trauma center in Springfield, Illinois, with the residents from the wonderful SIU emergency medicine program. And
Is that where the Simpsons are from? Springfield?
well, it's one of them. We don't know which Springfield the Simpsons are from. It's a closely guarded secret, but not
Okay.
here. In any event, although I do have a number of liver patients that do their best Simpsons impersonations, so maybe.
Maybe.
But anyway, Ken, I brought this study up because I looked at this study, and this is one of those where we were just talking before we started recording here. Details matter, and I think this is one of these studies that social media has completely proven the point of details matter, because this study, and it's a decent study, and we'll talk about why it is, I think, a fairly decent study. It doesn't say what people think it says.
Yeah. So what you're saying is that social media was misrepresenting medical research. We should have a trigger warning. People, pull over, sit down.
Yes.
I mean social media gets it wrong.
You know what else it is? It you have to read past the abstract and some of the details of the study.
Yeah, you got to go to my favorite section, the methods. Like, what was the question they were asking, and hey, what was the intervention, and what group did they compare it to, and what was the outcome, clinically relevant? All these really important things that you can find in the methods section.
And that's the part that's really burned the quick interpretation of this study, because when you look at this study, and we'll get into the details of it, but the bottom line is if you actually read kind of what they say and you make some assumptions, it says something totally opposite than what it means. And that is because what they basically said, and I'm not going to drop off the whole segment here, but they basically their conclusion said whole blood versus standard care. And in the United States, standard care doesn't always include blood.
Oh, hey, don't spill the candy dish here.
Okay, I won't.
Come on. Why don't we just set this up with a
Okay,
case?
okay.
And
You know me, I
let's
gotta
just
rush
go
into
through
things.
it.
You know me, I gotta rush. Come on.
Yeah, I know, and I maybe I'm burying the lead, but let's go through this systematically. Give us a case.
All right, let's take a case. Let's say, for the sake of argument, that you are getting a 36-year-old guy by aircraft, high-speed motorcycle crash. The flight team is telling you there's blunt polytrauma. This guy's hypotensive, tachycardic. They can't even really do a pelvic rock because there's so much pelvic instability. They're pretty concerned that there's intra-abdominal bleeding. They get access in the field, and they start pre-hospital blood. On arrival, guy's pale, cool, diaphoretic. Blood pressure is 86/52. Heart rate's 128. GCS at 13. They've got a pelvic binder in place, which we can argue about later. Abdominal distension is present, and there is a grossly positive FAST exam.
Yeah, we've got to throw some stuff in there that maybe is controversial, but this is did you notice that I didn't put that he had a collar on, a C collar, because I didn't want to trigger you in any way. But yes, pelvic binders. People come in with pelvic binders on still.
You didn't put ultrasound on the ambulance, so on the aircraft. So you kind of. They should have had
I'm just trying to make it practical for a rural hospital, critical access hospital, yada, yada, yada. But hey, traumatic hemorrhage is one of the classic time critical problems in emergency medicine. Patients don't die because of their hemoglobin on tomorrow's CBC. They die because they're bleeding right now in front of us. And it's one of the reasons that the 11th edition of the Advanced Trauma and Life Support, or ATLS, has formally now prioritized external bleeding before airway management. Believe it or not, it's no longer ABCs. And we covered that on the SGEM. The new mnemonic is X. A, B, C, D, E. I think that sounds cool, though. It's like I'm an X-Man now. And the X stands for exsanguinating hemorrhage. So they stretch that a bit to get the X instead of an E. But it stands for exsanguinating hemorrhage. And this reinforces early tourniquet use, direct pressure, hemostatic adjuncts as first-line priorities when appropriate.
And I think that, I'm not taking a side, but, I think that that's absolutely key. When you start talking about trauma resuscitation, it's always about the bleeding, right? I mean, we sit here and we argue about epinephrine and all these other adjuncts.
Stop the blood from leaving the body.
Yes. Well, and I think that, it's one of the things that I've always taught my residents, and that is if the heart kills the body, we can get you back with all these ACLS stuff. But if the body kills the heart, you're dealing with a whole different ball game here. So what we do know is that when we look at in-hospital based trauma resuscitation, the proper trials basically said we need to go towards balanced component therapy when we're replacing this blood, right? Now that we need to stop the blood from leaving the body, but we got to refill the tank. And in that randomized control trial, which was back in 2015, they compared 1:1:1 plasma, platelets, or red cells to 1:1:2. And basically the authors said, you get better outcomes in terms of hemostasis and fewer deaths from exsanguination at 24 hours, even though the primary outcome, overall mortality, was not statistically significant. They really wanted that. They really seemed to prove, and I think we've all moved to that balanced component therapy, right? 1:1:1.
Yeah, and the harder question really is what should happen before the patient ever reaches the trauma bay? And pre-hospital transfusion sounds like a really attractive idea, because if they're bleeding out there and we can start pouring in some stuff while we're trying to stop the blood from leaving, it could shorten the time to blood-based resuscitation. But the evidence, it's really been mixed.
Well, and it has been. And the PAMPER study showed 30-day mortality with pre-hospital plasma in patients at risk for hemorrhagic shock that were transported by air works, right? So like if you're going to give them plasma, if they're coming in by aircraft, you have a lower 30-day mortality, but the refill didn't show superiority for pre-hospital blood product strategy over saline. And so there's been some question, right? But a pool post hoc analysis of both PAMPER and COMBAT said that any benefit from pre-hospital plasma may be most apparent when transport times are longer and resuscitation has started early enough to matter. And I think that that's been one of the key issues too.
Yeah, and so for us as emergency clinicians, the real debate is not whether bleeding trauma patients need blood. They usually do. The more useful question is which product, for which patient, in which kind of system, and over what transport interval. That is why pre-hospital transfusion research keeps circling back to logistics, case selection, transport time, and whether a pre-hospital strategy complements what happens after the patient arrives in the ED rather than simply adding to the complexity of it.
And so now we'll get to that buried lead, right? Because the clinical question that they looked at in this study was in trauma patients with life-threatening hemorrhage treated by participating air ambulance services, does pre-hospital transfusion with up to 2 units of leukocyte-depleted whole blood compared with standard component therapy up to 2 units of packed red cells and 2 units of plasma reduce composite of death or massive transfusion within 24 hours? And it's that parenthetical after standard component therapy, because what standard component therapy was, what they were comparing whole blood to, was giving 2 units of packed red cells and 2 units of plasma. Not what lots of folks online have said, which is saline, right?
Or nothing. Yeah.
Right.
So it was, they were getting blood products. They were getting up to 2 units of packed red blood cells and up to 2 units of plasma. in the comparison group.
And so, when this study first came online and you went out and you just kind of taking the temperature of the room, so to speak, online, lots of people were like, see, this proves blood products in the pre-hospital environment doesn't work because they gave 2 units of whole blood and it was no better than standard therapy. Not to bury some of the discussion, because I don't think that it shows what that either. But the assumption was that the standard therapy did not include blood, and it absolutely did. So we're not discussing if we should give whole blood or if we should give blood products in the pre-hospital environment. We're discussing which blood products to give in the whole in the pre-hospital environment. And so this was by Smith et al. It's the SWIFT trial group, pre-hospital whole blood in traumatic hemorrhage, a randomized controlled trial. This was published in the March edition of the New England Journal of Medicine.
So why don't we go through the PCOT? What was the population?
Patients of any age with traumatic injury attended by a participating air ambulance service clinical team who required pre-hospital blood transfusion for a major traumatic hemorrhage.
And there was a number of exclusions. And remember, details matter. So I'll put those in the show notes. What was the intervention?
Up to 2 units of pre-hospital leukocyte-depleted whole blood.
And of course, the comparison was just this routine standard therapy, right? We can move on.
Yeah, sure. The comparison was 2 units of red blood cells and 2 units of plasma, thawed fresh frozen plasma or lyophilized plasma, depending on the service.
And okay, let's look at their outcomes. What was their primary outcome of interest?
The primary outcome of interest was the composite of death from any cause or massive transfusion within 24 hours after randomization. Massive transfusion was defined as at least 10 units of blood products, blood components or products in adults, and at least 40 mLs per kg in pediatric participants under 16 years weighing under 50 kilo.
And then they had a whole bunch of secondary outcomes. Again, those will be in the notes. What type of study was this, Howie?
This was my favorite. I kind of like these pragmatic, multi-center, parallel group studies. It was open label, unblinded, superiority, randomized control trial.
And the author's conclusions from the abstract, if that's the only thing you read, was, quote, among participants with life-threatening hemorrhage, pre-hospital transfusions of 2 units of whole blood was not superior to standard care in reducing the risk of death or massive transfusions within 24 hours.
This is where I wish they would have if they would have just defined standard care in the abstract.
So this would be your friendly amendment to that sentence.
My friendly amendment would have been not superior to standard care, and
say that was up to 2 units of packed red blood cells and 2 units of plasma.
Yes.
In reducing the risk of death of massive transfusions within 24 hours. Done.
I think that my note to some study authors as you move forward is realize that so many people, not our listeners, because our listeners want to know the details, but so many people will only read the abstract. So get a little more information in there, please.
All right, let's go through the quality checklist for RCTs. Did the study population include or focus on those in the emergency department?
No, this was a pre-hospital study. The intervention and randomization occurred pre-hospital, but these patients were definitely all subsequently in the emergency department.
Yeah, they were en route. They were on the way.
Yes.
Were the patients adequately randomized?
Yeah, I mean, randomization used a centralized web-based system with these random blocks of varying undisclosed size, and they were stratified by the air ambulance service. They did a good job at random.
Yeah, so they shuffled the deck well. And did they conceal the process, how they were doing this randomization?
Yep. Only sealed envelope and trial statisticians had access to the allocation list, and transfusion laboratories packed sealed trial boxes before dispatch to the air ambulance teams.
And were the patients analyzed into groups to which they were randomized?
No. I mean, the main analysis was modified intention to treat, not full intention to treat, with exclusions for non-traumatic hemorrhage, traumatic cardiac arrest on arrival. There was some withdrawn and some deleted data.
Do you think the patients were recruited consecutively?
They didn't really tell us, because the protocol was based on clinician judgment. So you had to figure out, first of all, whether they required pre-hospital transfusion. And so you don't really have truly consecutive enrollment.
Yeah, there's some subjectivity in there, isn't there? Were the groups similar?
Well, yeah. I mean, the baseline characteristics appear well balanced between groups, and that's what I was going to quickly aside on the were the patients recruited consecutively for no selection bias. I don't think the way that they did it introduced selection bias. Well, I think it's a great thing to look at, where they recruited consecutively, but I think that just given how this study, how the pragmatic portion of this study, I don't think that necessarily introduced selection bias, that they weren't.
And that's why the answer was unsure. It wasn't a no or a yes. It's like,
No, no,
we're unsure.
yeah.
Yeah. How about all the participants? This is getting into the masking. Were they unaware of group allocation?
No, and there's no way to do that because it's unblinded once the box is open, right? You know whether you're giving 4 bags or 2 bags.
Welcome to the pragmatic part, right?
Yeah.
Were all groups treated equally except for the intervention?
We don't know. The article stated that no other aspects of care were altered by trial assignment, but contamination and protocol deviations occurred. There were some controlled patients who ended up receiving whole blood. There's a lot that kind of goes on because, welcome to the pragmatic side of life, right? At a certain point, if I'm the doctor and I think I need whole blood on a patient that's in the control group and is dying, I'm not saving the study, I'm saving the patient.
Yes, patients first. Was the follow up complete?
Yep. For the primary outcome and mortality follow up, primary outcome missing data were about 4%. 90-day vital status missingness was about 13%. But there were some secondary and safety data sets that weren't as complete.
And do you think that they thought of all patient important outcomes?
I don't know. I mean, mortality and major morbidity outcomes were included, and the primary composite included a management sensitive outcome, massive transfusion, and some patient important outcomes like quality of life were planned, but they didn't actually report on it. So yeah, I'm not sure that all of the patient important outcomes were considered.
And when it came to their results, was the treatment effect large enough and precise enough to be clinically significant?
No. A primary estimate was close to null. There was no statistical difference, and the confidence interval crossed both potential benefits and potential harms.
And where'd the money come from for this study?
The old NHS. This was NHS Blood and Transport, participating air ambulance charities, the Ministry of Defense. The sponsor was NHS Blood and Transplant.
Okay. And did the authors have any conflicts of interest that they declared?
Unsure from the main paper files alone, but the protocol states that at the time it was written, the chief investigators, principal investigators, and trial committees had no competing interests with a plan for disclosure of any arising conflicts during the trial. And given who's funded it and what it's talking about, it's hard to see.
Unlikely.
Right. It's unlikely. I don't. We can talk about big pharma, but I'm not sure there's big blood out there.
Big blood. All right, let's get into the results then. They had about 900 plus patients who were randomized overall. So getting into the trial, there was about 900, I think it was 942 exactly. But then after exclusion and data removal, they were left with 300 less patients. 641 participants comprised the modified intention to treat analysis. The primary analysis used complete cases. So there was 314 in the whole blood group and 302 in the standard group. So fairly balanced, 300 in each group. Most participants were male, no surprise there, like 3/4 of them, trauma. The majority was blunt trauma. And I think this is important for people like me in Canada and in the UK. Most of the trauma that we see is blunt trauma. And that may be different from what you see, Howie, in the US, because you have a lot more penetrating trauma than other places. And then the median age was 38 years old in the whole blood group and 35 years in the standard group. So I don't think that was a big deal.
Ken, just to go back to that point, though, I think that where we're looking at a whole lot of pre-hospital blood products, the penetrating trauma that we're seeing in the pre-hospital environment tends to have short transport times, and tends to, there is still the broad question of whether it is better to, and this would be a whole different study, but whether it's better to scoop and run with those folks, because that's what the data seems to indicate. And are they better off getting to the hospital just rapidly because they're in the inner city, as opposed to that?
Yeah, I think it's a different patient population.
I guess my point is that to what we actually receive at a major trauma center, in terms of via helicopter,
It would be majorly blunt.
it would be. It would be about this. It would be for what's coming in by bird. It's going to be about this 71%. I think is fair. I think if we're going to include everybody who comes into the trauma bay, no, it'll probably skew more. There'll be less blunt trauma, but not by as much as you'd think, but definitely enough to affect a study. But as far as is this applicable, and we'll talk about it later, it probably is. Anyways, let's get to the result.
Okay. What was the key result they found?
Key result was that pre-hospital transfusion with up to 2 units of whole blood was not superior to standard component therapy for reducing 24-hour death or massive transfusion in patients with life-threatening traumatic hemorrhage. And so what they did, the primary outcome occurred in 48.7% in the whole blood group and 47.7% in the standard care group. So the relative risk was 1.02.
Yeah, it wasn't a statistical difference. It was like 49% in the whole blood group had the primary outcome and 48%. So there was only a 1% difference between the two groups. And so, the relative risk, we're not even talking about like absolute risk being a small number. The relative risk was still only 1.02, spanning fairly evenly along that 95% confidence interval. How about the secondary outcomes?
So mortality at 6 hours, 24 hours, 30 days, and 90 days appeared similar between groups, as did the rate of massive transfusion and most other secondary outcomes.
Now, there was one notable difference, and again, this is secondary outcomes, and that was in prothrombin time above the normal range was more common in the whole blood group, by about 10%.
But serious adverse events were slightly fewer with whole blood, 31 versus 37. Thrombotic events appeared similar, and 2 transfusion-related shot type events occurred in standard care, with none reported in the whole blood. But I would argue that may be a sample size
issue. Yes. Okay. Well, let's talk nerdy. This is what I love to do. This is what I love to do with the guests that come on this show. So let's talk nerdy. And since I brought up the modified intention to treat analysis, I'm going to start with that. And in this SWIFT trial, the main analysis was this modified ITT because they excluded non-traumatic hemorrhages, traumatic cardiac arrests on arrival, and patients whose data were withdrawn or deleted after serious protocol breaches. On top of that, the primary analysis was effectively a complete case analysis with a modified ITT population. And some of these exclusions, they made sense. They were clinically reasonable to exclude those patients. But at the end of the day, it still does weaken the integrity of the randomization process itself and raises the potential that excluded patients were different in some important way from the included patients.
Well, and the other problem is that it was open label, right? Because once the box is opened, this is an unmasked trial. And death is a hard outcome, but massive transfusion, that's not biological and somewhat subjective and could depend on clinician decisions, local transfusion behavior, downstream management. The composite's more vulnerable to a performance bias than a purely objective endpoint such as mortality alone. The whole thing comes down to how is somebody going to react, right? You might have somebody who says, I like permissive hypotension, right? I'm a Maddox devotee. And, you gave them 2 units of packed red blood cells and 2 units of plasma. That's a whole lot of fluid. So I'm going to hold off on giving something else because I'm worried it's going to cause, relative hypertension because the volume was bigger or something along those lines. I mean, to give you a crazy example. But yeah, when we're starting to talk about having massive transfusion as an outcome, that's a clinician pulled trigger that doesn't really have a definition, and certainly could be influenced because the people making that decision know darn well whether they got whole blood or component therapy. Now, would it realistically change their behavior? I don't know.
Well, you work in various locations, as do I. I work in different centers, and each place I go to has a little culture to it, has a little nuance, has a little sort of that's what they do there. And this was selected ambulance services, air ambulance services that decided to participate in this study to begin with. And then you have the different locations. And so you can see, well, at our center, at our level one trauma center, you've got some champion who likes to do this, whereas at the other place, they've got some other champion that likes to do something else.
Well, and now right. I would say it's not even the local culture. It may even boil down to individual trauma surgeons. I'll tell you that where I work right now, I love and respect every single one of my trauma surgeons. But what I will say is what I've told my residents about differing emergency physicians, and I think it plays true here with different trauma surgeons. Right? It's like watching somebody. It's like watching a master chef cook a steak. Right? Some of them use pepper and salt, and that's it. Others use sage and garlic and basting and whatever else. You're not going to tell either chef they're wrong, and you get a great steak either way. But man, is it a different preparation, right? And so some of my trauma surgeons, the way that they cook their trauma is very different than even their partners. Doesn't mean that they don't get great outcomes and that I wouldn't trust any of them. I trust all the ones that I work with. They're wonderful, but they do have different approaches sometimes.
But that's the heart of evidence-based medicine, right? We have the evidence that informs our care and guides our care, but most of the evidence in this area is kind of weak, and that's not unique to this area. And so we don't have very thou shalt do this and thou shalt do that. And so we've got to back off a bit and not get on our high horse. And we've got to rely a little bit more on our clinical judgment and our clinical experience. And then, of course, engage with the patients and their families about what they prefer and what they value. So I can see there being variability and subjectivity to whether or not you pull this trigger and do a massive transfusion protocol.
But if you don't cook a steak with some garlic, you're wrong.
Oh, okay. Yeah. Well, there's a hill you're going to die on. Okay. So let's get to number 3, and that's about contamination and protocol slippage. And I want to be clear, contamination is not contamination of the blood products. That's not what we're talking about here. It's talking about doing a clean superiority trial. And that needs a meaningful separation between the two groups that you're looking at. Like there has to be something distinctiveness between them. And in the SWIFT protocol, deviations occurred roughly 7% of the time in both groups. And then there were some randomization errors. Again, this is a pragmatic trial. Studies are messy and they're difficult to do. So it's not a condemnation of the trial investigators. Doing research like this is really hard. And so they got randomization errors in about 5% of the patients. And then 7 participants, and remember the total trial was about 600 and something, 7 participants in the standard arm received whole blood pre-hospital due to mispackaging of the boxes or because only whole blood was available at the time. There was also co-enrollment in other studies. So they were doing more than one study and including some deemed non-permissible, so you couldn't include them. Now, none of this, of course, invalidates the study outright, but it can dilute the difference and it certainly can make us less confident about the groups that make a truly superior intervention in this case. It would be harder to demonstrate that you've got something superior here when you have this crossover and this messiness and this fuzziness.
Well, and also I think we have to look at the lack of power, right? Because the trial is powered for the primary composite, but not for most secondary outcomes. Meanwhile, as you point out, missing this was modest for the primary outcome, but was substantial for some of the secondary and safety measures. 90-day vital status was missing in roughly 13%, thrombosis data in about 19%, trauma registry severity variables in about 31%, incomplete follow-up and selective availability of outcome data really kind of weaken our confidence in the estimates, especially for the secondary and safety analyses, which makes me a little skeptical here.
Oh, I like that term.
But while thrombosis and serious adverse event findings are reassuring, they're not definitive here. We're missing a lot. Like there's some gaps here.
All right, let's talk about the fifth and final point. And that's about the external validity, and we sort of touched upon that a bit. SWIFT was a pragmatic trial, and that is a strength. However, the decision to open a trial box depended on the clinician's judgment that the patient required pre-hospital transfusion. That makes the enrolled population highly relevant to a UK air ambulance practice. It also makes it harder to know how reproducible the entry decision would be across clinicians, like you mentioned, like individual clinicians, ambulance services, or in countries. In other words, the study tells us a lot about a mature physician, paramedic, air ambulance system that's functioning in England, but it tells us less about ground EMS, different blood supply models, shorter transport times. How about longer transport times, like in Canada, where, uh, like England is small compared to Canada? That's more of an external validity concern than an internal one, but it still matters when deciding how far to generalize these findings.
I couldn't agree more. Yes, there is certainly some of all of these questions, and these are great points. Everybody gets a shiny new toy and wants to play with it. As you point out, it's different. You're looking at a physician, a very mature physician, paramedic air ambulance service in England. You don't necessarily have that in the most of the United States. There's only a couple of services that fly with physicians on board, and almost all of them are physician nurse in the U.S. For a variety of reasons. And as we point out before, there may be a difference in the composition of the types of trauma, as you point out, transport distances, and all of the above.
It'd be nice if they did a, they've set, they've got the methodology that you could try to replicate this in Australia, in Canada, in the U.S., and see if they set up similar methodology. Then you could do a meta-analysis on this and see if it does have general applicability beyond just we know the results come out in the UK.
But I think we can agree that we generally agree with the author's conclusions here.
Yeah, generally, except for we would have that friendly amendment to include that it was not just standard therapy, but to give a little bit of detail. Even if you said standard component therapy, would be helpful. So you knew you weren't comparing it to saline or something.
Yep. So the bottom line, whole blood's feasible. It's reasonably safe in a UK air ambulance system, but the trial did not show superiority of whole blood over standard component therapy.
All right, and how about the resolve that case that you presented at the beginning?
Well, the patient's in hemorrhagic shock from major blunt trauma. The priority, honestly, is to get this patient treated, right? We're not going to debate the blood product philosophy there at the bedside. So we got to activate the trauma and the major hemorrhage pathways, continue rapid blood-based resuscitation with the product that your system can deliver immediately and reliably, control hemorrhage fast, pelvic stabilization, damage control surgery and or IR, plus adjuncts like TXA and cryo where appropriate. And you have to avoid assuming that the whole blood is clearly superior to balanced component therapy, because this trial did not show superiority.
Yeah, I like that. Now is not the time to have an esoteric debate or a philosophical discussion amongst yourselves at the patient's bedside. No, now's the time to save the patient. And you can have these esoteric, and maybe not esoteric, but philosophical, or you can debate the literature, but let's do that over a coffee or some other beverage in some kind of social setting or academic setting where we can really hash things out and then come up with an approach.
Absolutely. But I think clinically, we can say that whole blood is a reasonable option in systems that can store, deliver, and safely govern it. I think standard balanced component therapy is also a reasonable standard. Decisions should be driven by logistics, transport interval, wastage, donor availability, training, how well the pre-hospital strategy integrates with the trauma bay care, not by the assumption that whole blood is automatically superior. And I think that this really is where the rubber meets the road. I like this trial because I would almost flip it, right? While it doesn't show that whole blood is superior, it also doesn't show that whole blood is inferior. And the KISS guy in me, right, the keep it simple stupid guy in me says 4 bags good, 2 bags better, right? Like if I have the option of carrying 2 bags of something versus 4 bags of something, and I'm going to get essentially the same outcome, I may lean towards the whole blood just for the much more pragmatic approach of I got less to do.
Yeah, so that would be very much like a non-inferiority study, almost like, the advantage is we've got 2 bags to haul around and maintain and document and stuff like that, as opposed to 2 units of packed blood cells and up to 2 units of plasma. We just got 2 units of whole blood products.
Yeah, and I think it does, introduce having whole blood versus component therapy does also eliminate one source of error that never gets discussed, and that is, what happens with the person who decides to only give the packed red blood cells or only give the plasma for whatever reason, their own professional judgment, which then takes us off of pathways where we really may decide that the entirety would be better to just take that decision out of their hands and to leave us with whole blood. So I think that the clinical application here kind of goes both ways, right? I think it proves while it doesn't prove the superiority of whole blood, which I think a lot of people expected it to, it also doesn't show that it's harmful. And so I think it remains. I think it doesn't elevate whole blood to superior, but it does certainly suggest that whole blood can be given with reasonable confidence and with certainly no significant signal that it's more harmful than standard component therapy.
And so what are you going to tell the patient quickly at the bedside?
Yeah, I'm going to stop your bleeding, dude. I'm not telling the patient a darn thing because the most important thing to do with this patient is stop their bleeding and control the bleeding source and refill the tank and keep them from dying. I think the patient's not going to get a whole lot of talk about from me at the bedside. But when my paramedic asks me afterwards, which way should it go, I'm probably going to tell them, certainly based on this trial, that there is certainly no evidence that whole blood is superior, but it also doesn't look like it hurts. And as long as we're getting something to refill the tank besides salt water, we're probably doing the right thing by the patient.
All right, that leads us to the Keener contest, and last week's winner was Dr. Tim Kolsinak, and of course, I am going to mispronounce his name. He is a medical toxicology fellow at Lehigh Valley in Jefferson Health, Allentown, Pennsylvania, and he knew that severe sepsis was the term that was retired. What's the question this week?
What does massive transfusion typically mean in adult trauma trials?
Yeah, and just to be clear, it is not the typical transfusion in a critical access hospital where I tend to work a lot, because that's both units of O-neg.
And O-pos if you've got any.
Yeah. It's like, okay, let's trigger let's trigger our massive transfusion protocol. Call the lab and they go, so you want both units? Yes, I would. Thank you. All right. Well, there's some other FOMED on this. Our friends at First 10 EM, Justin Morgenstern did some stuff on this, and so did our friends across the pond over in the UK at St. Emlyn's, and I'll put links in the show notes. Thanks, Howie, for bringing this study to my attention and suggesting that we cover it.
Hey, absolutely. I appreciate being on and definitely enjoy talking with you at all times, Ken.
That means I get to go on your show next, though, right?
Hey, my show is we'll talk, but my show will be coming back, but it's going to be October-ish before we're going to relaunch due to some.
I serve at your pleasure, Howie, and I'd be happy to be on at any time to talk nerdy.
I do appreciate that, my friend.
Can you read the SGEM tagline before we go?
Of course, remember to be skeptical of anything you learn, even if you heard it on the Skeptic's Guide to Emergency Medicine.